But the good news is it's pretty relatively straightforward and simple treatment for only a couple options that we'll talk about. There's good old Kent and Alley. All right, so we'll define it, talk about pathophys. We'll look at the clinical evaluation, our treatments for it, and really it's relatively simple. It's whether we're going to put a tube in there to drain that air, or whether it's small enough that we can allow it to heal on its own. All right, let's do a check on learning here. Hold on, it's real small unless I can see it. All right, 68-year-old female presents to the emergency department, low-grade fever, dyspnea, productive cough, fatigue for the past 2 days. It's a history of diabetes and hypertension. Vital signs are blood pressure 135/76, heart rate 84, respiratory 20, 100.9 fever, SpO2 94%. Lung exam is significant for diffuse swelling and freckles in both lung fields. What is the recommended treatment based on the most likely diagnosis? So what are we thinking here? What does it sound like? We covered it yesterday. Yeah, pneumonia, right? I know you guys probably aren't looking at it yet because the test is until the end of the month. Yeah, it's going to be E, right? Outpatient treatment with amoxicillin, with clavulanator, augmentin, and azithromycin. So this is a stable patient. Vital signs are stable. This is going to be the outpatient with comorbidity treatment for it. So we just broaden our coverage a little bit more than we normally would. If this was, a younger, healthy patient without comorbidities, it'd be, amoxicillin and Zithromax or azithromycin. And then, since she has comorbidities, it's going to be amoxicillin clavulanated with the Zithro. Everybody good on that? Well, comprende? All right. 74-year-old female is brought to the ED by her husband for fever and cough. Vital signs are blood pressure 90/60, heart rate 112, respiratory 24, 101.1 fever, SpO2 88% on room air. So this patient, stable, unstable? It's going to be an unstable patient. So on physical exam, she appears ill, diaphoretic, past medical history of diabetes and heart failure. Chest x-rays shown below, not look good. Based on the most likely diagnosis, what's our treatment for this one? So what category does she fall under? When we're looking at whether it's outpatient, young, healthy, no comorbidities, outpatient with comorbidities, inpatient, and then inpatient, and then this is going to be our sepsis patients, like an ICU sepsis patient. She's unstable, blood pressure's right on the borderline, very soft, tachycardic, tachypneic. Yeah, this one's going to be delta. So this is going to be that triple therapy. So we're going to cover with beta-lactam. We're going to use an anti-sodomonal medication, and then we're going to cover for MRSA too. So that's our beta-lactam, fluoroquinolone, and vancomycin. All right, so let's talk about a little bit about COPD. Which of the following medications has little or no clinical indication when treating a patient with acute COPD exacerbation?
A?
Yeah, A, right? So if they have COPD exacerbation, we're going to give, an inhaled short-acting beta agonist. We're going to give that anticholinergic like they do in that. They'll get on oxygen. They'll get steroids and antibiotics. So magnesium, what is that for? What exacerbation do we use that for? What's that? Asthma. So that's going to be your status asthmaticus patient that we can add on there as magnesium. We don't use it in COPD. And then thinking of COPD, what's the only intervention that is shown to improve mortality in patients suffering from COPD? Oxygen. O2. Let's see. Oh, got another one. All right. That's old. 90. So anybody that old shows up at the ER, I'm like, oh crap. I'm not sending them home, no matter how well they appear. 91-year-old female is brought in by her daughter for a 2-day history of frequent falls, not acting herself in a cough. Daughter states she's been living with her for the last 6 months after mother suffered a stroke. Medical history significant for hypertension, CHF, hyperlipidemia. Vital signs 102, 68, heart rate 98, respiratory 18, 100.3, temperature and SpO2 96 on room air. Lung auscultation reveals Ralls in the lower right lobe. EKGs without evidence of acute process. Chest X-ray labs are pending. Extremity exam does not reveal edema, which is the following most likely diagnosis. Yeah, this one's kind of like a process of elimination in this patient. So, maybe not 100% clear cut aspiration pneumonia, but those are the options there. Especially, you got an EKG, we'd probably like a troponin with it as well. There's no signs of edema, unlikely, PE less suspicious for, and no history of COPD, so this one's going to be an aspiration pneumonia. And it is more common in in elderly patients, especially, with this patient and her presentation. All right, here's a warm-up case. So, 17-year-old male presents to the ED complaining of sudden pain in his chest and difficulty breathing to start after a workout, and has history of trauma, recent illness, past medical history. He's young, healthy. Vital signs, stable. Right lung fields are cleared, auscultation, and the left lung fields are absent. The rest of the physical exam is unremarkable. Based on the chest X-ray, what is the next best step in managing this patient? Has anybody ever treated pneumothorax before or done chest tube? Some people, yeah. So this patient, you're going to need a tube thoracostomy, so that's the completely collapsed left lung. This is actually my best friend's son, this picture. Like a couple months ago, he was, I diagnosed him in my kitchen. He's like 6'4", 140 pounds at the most. He vapes, and this had actually been going on for 5 days. And he was seen at an ED, they didn't do a chest X-ray, and then I just was talking to him for 10 seconds, and I was like, he couldn't complete a full sentence. I was like, dude, you got a collapse lung. And he's like, well, it's a muscle strain. And he's like, and coughing while he's talking. I was like, no, dude, let me listen to your lungs. And yeah, it's completely collapsed. You had to get a chest tube, you had to go to surgery. So, and we'll talk about it here in pathophys and what causes this, these spontaneous pneumothoraxes. All right, so our approach is the same for, all of our patients. So we always want A, B, C, D, E. Initially we'll place the patient usually on a 100% oxygen non-rebreather, and the important thing to consider here is, or to remember, is that a pneumothorax is a clinical diagnosis, so we don't need chest X-ray or imaging. If we suspect it, then we'll treat it. With that said, if it's a tension pneumothorax, so if that lung is collapsed, it's compressing, or it's moving the mediastinum into the contralateral lung, and they show appropriate vital signs, like unstable vital signs with it, we call it tension. So that one we'll do immediate needle decompression followed by tube thoracostomy. And that's a definitive treatment as well. All right, so let's talk about it. So have you guys covered it in surgery? I don't know. Oh no, that's block 3, that's trauma lecture, so probably not yet. I think there's like a slide on spontaneous pneumo randomly interspersed in there. But so some sort of air enters that space between the visceral and the parietal pleura, and it causes, a portion of that lung to collapse, and it's, we'll talk about different sizes, but it might need to be reinflated or a tube in there to help reinflate that lung. And we break it down into whether it's primary versus secondary. Primary is usually from, like that kid I was just telling you about, like a spontaneous pneumothorax. They don't have any history of lung disease. And a lot of times we call primary associated with trauma as well. Secondary is usually some underlying lung disease, more commonly like COPD, things like that we'll see a pneumothorax with. All right, and here's some risk factors that are associated with like a primary spontaneous pneumothorax. So cigarette smokers, vapors, and more common in males. They have, mitral valve prolapse. They're like marfanoid or Marfan symptoms. Changes in ambient pressure, like if you're flying or diving, you might see this, and then familial patterns as well. I've only had one like Marfan's patient. He did not look like a Marfan's patient, but he had like an aortic dissection, like a thoracic aortic dissection randomly, but he ended up getting genetic testing and they figured it all out. But definitely not what I was expecting. He was one of my like soldiers, one of my NCOs, but yeah, he did not have that like Marfanoid looking appearance. So I don't know how it works, but that's what we're taught. And that's how we look at it for board questions. All right, so here's some of our secondary pneumothorax. So like we have highlighted, like COPD is a common one in developed countries or like first world countries, and then in the third world or whatever they call it now, developing nations, you'll see it with tuberculosis. Is actually the most common cause worldwide that we see. There can be all kinds of other causes there, like connective tissue disorders, like I said, Marfan's or Ehlers-Danlos, any sort of cancer, and then those other ones like sarcoidosis and things like that. HIV is very, not very common, but it can be a cause. So, like I said, you got that visceral and parietal pleura, some sort of pressures created in there. We're usually from a ruptured bleb if we're talking about primary spontaneous pneumothorax. But they come into contact with each other. You have a little bit of fluid in there. They kind of slide, and during your inhalation and exhalation, the chest wall expands. And normally there's no problems. However, when you get, with the primaries, especially with trauma, any sort of penetrating injuries, it's a large area, and so we run a risk of something damaging that process. All right, like I said, so primary, oftentimes it's from like a subpleural bleb, which is what happened to my friend's kid. He had a bleb rupture, and they actually needed to get like a couple surgeries for it. Then we have our secondary, so something disrupts it, usually from that pulmonary disease process. And those can be a little bit more tricky with that underlying lung disease, so we tend to evaluate them a little bit more if they're stable before we put a chest tube in those patients. All right, so yeah, once we get that pleural break, that air travels down the pressure gradient into the pleural space, it collapses the lung, and most often, depending on the size, and we'll talk about like 20, 30%, depending on what you read, they're often going to require some sort of intervention, whether that's a needle, whether that's a pigtail catheter, and we'll show some of the pictures and different treatment options we have for these patients. All right, so this is what we worry about, is this tension physiology that we talk about. So, and this gets tricky on tests. Everybody, people get confused on it. And really, any signs, like in your history, anything that could indicate a pneumothorax, and then you look at the vital signs, whether they're stable or unstable. So if they're unstable, we will call it a tension pneumothorax. And really, it's that increased pressure pushes all of your mediastinal contents to the opposite side, and that can result in shock and hypoxemia, and a lot of downstream bad effects. You can get that tracheal deviation and things like that. But the classic symptoms for primary spontaneous, that sudden onset shortness of breath. They'll usually have chest pain on that side, or pleuritic chest pain on that side. And, some components may resolve within the first 24 hours. Like that kid I treated, my son's friend, he had it for 5 days, and his O2 was still like 96% when we took him to the ER. So people can compensate really well. It's kind of impressive, like living on one lung for 5 days and still working. And he's like, it's just not getting better. I'm like, oh, I guess we found out why. And then the most common physical exam is going to be that sinus tachycardia. Then here's some other, things you might see. Those, decreased breath sounds, hyperresonance. I'll be honest, I've never seen anybody do tactile phrenitis, but I guess you don't have any other means to diagnose it and you're unclear about whether this is a pneumothorax, maybe that'll help you. But once again, physical exam alone is not sensitive enough to exclude the diagnosis. And what we do a lot of times, if you guys remember have you guys taken BLS yet? No, probably not, right? But you probably briefly covered it. And when we're doing like a cardiac arrest, or when we have any concerns and questions, it says reversible causes on there. So a lot of times in a patient where we don't have a great history, they came in arrest, if we're not able to resuscitate them or revive them, a lot of times we'll put a chest tube on each side just to see if we can fix that problem, because maybe it is a tension pneumothorax that caused it. So it is a clinical diagnosis, but the clinical hallmarks of this, tracheal deviation, that's kind of a later sign. You get that hyperresonance, but what we worry about is that hypotension, significant shortness of breath, tachycardia, they'll be hypoxic, and then you see JVD with it as well. So this patient's definitely going to get a chest tube, so anybody with tension pneumothorax. The protocol, so this is where it gets tricky when you're testing, and a lot of people always get mad about it. Because in the hospital, so the protocol is you start with a needle decompression followed by a tube thoracostomy if it's tension pneumothorax. Well, in the hospital, we're, in a trauma center like at BAMC where I train, we're already there ready to go. We have scalpels in our pockets that we walk around with, and we're ready to perform this procedure right off the bat. Most trauma centers the same way. So we don't do the needle decompression a lot of times, but that is the standard protocol. Tension pneumothorax, needle decompression first, followed by a tube thoracostomy. However, if they're stable, then we can look at doing just a tube thoracostomy. How do we diagnose it? Chest x-ray works really well for this, and it's usually our initial test of choice. Most patients that come into a trauma center, we have our point-of-care ultrasound, our fast exam that we perform during our primary survey, which is our ABCDEs. So it's like an adjunct to that. So sometimes we'll be able to diagnose it a little bit quicker with our point-of-care ultrasound. And we'll show some pictures of how we diagnose that. And then here's probably the worst x-ray I've ever seen. It's all blurry, you can't see. So it's a completely collapsed right lung. All right, then there's our ultrasound. So, its sensitivity and specificity, it's great. And then we'll discuss those different findings that you have on there. And then during your ultrasound block, we'll scan each other. I mean, we're probably not going to find a pneumothorax, but that would be interesting. I haven't seen one here yet, so hopefully it stays that way. But here's kind of how it looks. So we put an ultrasound probe on there. And that ultrasound probe will look down into the lung, and we look for lung sliding, and it can be complicated at first. But the good news is, just like your physical exam, how you guys practice over and over and over, you'll see a lot of normals. And then that'll help you once it's abnormal, you're like, oh, that doesn't look like it normally does. So what you'll have is that you're supposed to have lung slide in there. Did it do that one? See if the video goes. So you guys see how it kind of shimmers with that pleural line? We call it ants marching across the pleural line there. And that's in between two ribs is where we get this view. And so that's what the normal is supposed to look like. And then this is abnormal. So are you guys able to see the difference, Harvey? How it looks just like a solid line. There's no real shimmering or movement in it, or those ants marching across the screen. So that'll be a positive ultrasound or EFAST exam when we're performing it. All right. We also have something called M mode on our machines. And so it looks at the wall motion, but it projects it in a different pattern. So we tend to call this the seashore sign versus the barcode sign. So with one of them, you guys can see it looks like maybe like a sandy shore. Above that, maybe that's your shoreline there, and then this is your sky. So that's normal. That's what we want to see. And then if it looks like a barcode at the store, then that's going to be positive for a pneumothorax. I've actually never heard it called the stratosphere sign, but I guess they also call it that. All right. So this is a good picture because you have normal lung sliding and then you have absent sliding. So you can see how it shimmers there. There's the lung point, and then you have no movement after it. So that's indicative of pneumothorax. What do you guys think about this one? Positive, negative?
Positive.
Yeah, it looks like pneumothorax. Good. All right. And then there's another one. So which one's the normal? A or B?
A.
Yeah, A. Good. Perfect, you guys are experts. And we have some more. We'll just keep beating this dead horse. Which one's positive?
Right.
Yeah, good. Good job. All right, so chest CT is a great, very sensitive, specific adjunct, but however, we don't need it. We don't even need a chest x-ray because it's a clinical diagnosis for a pneumothorax. But if there's any question of, or it's equivocal on your physical exam ultrasound, chest CT is a great test for this. And a lot of times we'll do this in those patients with questionable, maybe it's like apical pneumothorax, it's 10 to 20%, kind of equivocal on our exam. What does equivocal mean? I'm only asking this because every time it's on a test, I get somebody to raise their hand. I'm not going to every time. They're like, so the last time I was like, what's equivocal mean? Or they go, what's equivocal mean? I said, inconclusive. And they go, what does that mean? And I was like, oh man. So yeah, uncertain or questionable in nature, like open to more than one interpretation. It's ambiguous. So it's not positive, it's not negative, so you can't really hang your hat on whether you think it's a pneumothorax or not. So that's what equivocal means when you see it on a test. We always joke that we should have like a thesaurus at the front of the room so we can go, what does this mean? Not that anybody would get up and do it. But the good news is, the CT is going to be, an important test because we can find those pulmonary blebs. You can also find any underlying pathology or lung disease with it as well. It's more sensitive for looking at, like if you have an effusion with it or a hemothorax as well. So you get some blood in there. All right, and that's what the CTs look like. Normal, abnormal, what do we think? It's hard, right? You guys don't get a lot of CT training. One of the things I'd recommend, like in phase 2, especially in the emergency department, we always have a giant impacts machine that you don't even need to log on, we all look at. So I would always go on there, look at all your images, just look at CTs, ask your preceptors, hey, explain this to me. They probably won't be able to, but they'll try. And tell you what they're looking at. Yeah, this is a normal CT. So you see that pulmonary vasculature, you have that that dark area where air should be in the lung. Then you've got all your soft tissues, bones, and everything else around it. You have your vasculature there with your aorta and your heart. Now it's pretty clear, right? That does not look normal. We got that dark area there, so that's certainly a right-sided pneumothorax. Everybody agree, right-sided? Everybody know how to look at these. You're looking at it like it's the patient's feet in front of you and they're laying down on their back. Okay. I know it's been a while since radiology, so I just want to clarify it a little. Yep. There's another positive. It looks like maybe some tension physiology on that one. I would question why you're ordering this if it's a tension pneumothorax and they're unstable, but maybe they were stable, who knows? And I don't even know if I'm looking at it here like, this is completely gone. It looks like bilaterally, but it looks like it's, certainly tension physiology, it's protruding into, you have the mediastinal contents, not where they should be, so they're on the left side of the chest. So this is certainly a positive one. I don't know why you would have gotten a CT on this because they're probably dying, but hey, it happens. That's why we say in emergency medicine, don't send your patient to the CT scanner to die. All right, so treatment, like I said earlier, relatively simple. So if it's a large pneumothorax, which there's lots of debate on different sizes, and we'll cover it on some slides here. The general rule of thumb, some societies say 3 centimeters, some say 2 centimeters, depending on what you read. And we measure that from the apex of the lung. And we measure it down to like what we call the cupula of the lung, which is basically the lung point or the top of the lung, you measure it in centimeters on there. And then we kind of decide whether, usually anything more than 20% will likely need a chest tube or a tube thoracostomy in those patients. Anybody that's unstable or tension physiology, we do the needle decompression. Or sometimes we'll just make a decision to put our finger in there to help relieve some of that tension, air, or blood that's in there real quick, and then we'll put the chest tube in. But everybody needs oxygen for these, and sometimes if they're small, we'll observe them. What's difficult, let me go back, it's on the next slide, yeah. So we want to decide, is it spontaneous versus traumatic? Is it primary versus secondary? And then we measure that size from the apex to the lung of the cupula. Then we decide, like small, less than 3 centimeters, some guidelines 20%, some say 2 centimeters, depending on where you're at. Really, a lot of it's based on the patient's stability. And then there aren't real clear guidelines on sizes. The way we look at it in the ER is like there's small, and then there's not small, and then there's tension physiology. So if it's small, then we can think about avoiding that tube thoracostomy in that patient, and we try them on oxygen therapy. So oxygen has been shown to help resolve this a lot faster. And we have some metrics here. So oxygen has a 3 to 4-fold increase in pleural air resorption versus no oxygen. So like it says, if it's 25%, it would take 20 days to resolve. However, if we put them on oxygen, it can resolve a lot faster. And then observation, if it's small, the patient is stable, we'll put them on oxygen and we'll observe them for 4 hours. We'll repeat the chest x-ray. If we see signs of improvement, no pneumothorax, they're asymptomatic, then they can likely go home. We usually still don't send them home. We usually admit them for observation for 24 hours, but the textbook answer is, I guess in the right setting, you could send them home. If it's a first-time pneumothorax in a healthy patient, it has a higher chance of reabsorbing. Like in that patient, my buddy's kid, it definitely wasn't reabsorbing. That was like a completely collapsed lung. He needed a chest tube. And we'll talk about the different tubes we place in them. Sometimes we place small catheters versus large catheters. But here's like our criteria for a stable patient. So the respirators, less than 24, no shortness of breath. They can talk in full sentences. Pulse, relatively normal-ish as long as it's less than 120. They got a normal BP, O2's over 90, and we don't see any blood in there or pneumothorax. Then that's a patient that's a stable patient, and we then have to make a decision whether we want to keep them or send them home. So anything larger than 3 centimeters, like over 20%, and no, I'm not going to ask you the different percentages. We'll have x-ray, you'll have to evaluate some x-rays or chest x-rays and decide, like, that looks big, probably a chest tube, versus it looks really small and they don't need one. But large pneumothoraces and those with any air leaks, usually that's associated with trauma, they're unlikely to resolve on their own, so we'll place a chest tube in them. And this is something you guys won't see frequently, but you'll see it sometimes. Like I had, they always say this like tall, skinny person has a spontaneous one. Like I think the one I had, the spontaneous before the last one that was like marfanoid looking, she was like, I don't know, like 4'11", like 30-year-old Asian female. So not the patient I was expecting it in, but on my exam I was like, yeah, something ain't right. She looks sick. So I got a chest x-ray and I was like, well, that's not what I was expecting to find, and she actually required a chest tube. But we did a little pigtail. We'll show you what those look like here in a minute. All right, so what do we do for needle decompression? So we use, the recommendation is a 14 gauge large needle. So it's 3 1/4 inches long. I think now they have like 4 inches or 4. It looks like I can stick it through somebody's entire body and hit the bed with some of the newer ones, but the traditional, and the ones that, a lot of people, I think they still don't come in the IFACs and everything like that, so everybody has that long 14 gauge catheter. So that's what we use for needle decompression. And traditionally, it was a second intercostal space, mid-clavicular line, so right around here. We would place that needle. What we found is different body habituses, especially in the military, they're usually a lot fitter. They got a lot of muscle in that area. So sometimes we weren't having success with those. So now the recommendation is, between that fourth and fifth rib, that fourth intercostal space at the anterior axillary line. So that's recommended, I think, for TC3 guidelines and all that now too. So it's usually a little bit higher success rate for that. That location, like when the war first started, like I was a combat medic and all we had were like 1 1/4 inch 14 gauges. And I stuck like 4 in somebody and I didn't get nothing. It was like no relief. So that was before we had those 3 1/4 inch long needles. So it is important that you use the right catheter when you're doing this. And we'll actually have you guys practice this. We have our advanced trauma management lab, which is our K-prime lab. And it's live tissue, so we'll collapse some lungs in our model, and you guys will have some practice doing this procedure, as well as tooth thoracostomies and chest. So, all right. So here's a little graphic, representation of those locations that you're going. So there's the anterior axillary line, and that recommended space. We call it here. So for the anterior axillary line, we call it like the triangle of safety here, where you want to go. So it makes like a little triangle here, and it kind of comes down because we don't want to put it in their liver or anything like that, or in their abdominal cavity. So like a good rule of thumb is the patient's hand under the armpit and going right where their pinky is another rule of thumb you can use. The problem is you have to take the patient's hand to do it, and nobody ever wants to do that. So we kind of estimate some rules of thumb are like 1 up from the nipple line is a safe location as well. All right, so then we have other treatments we can use as well with different size catheters. This is one that's in the textbook. I've never used just a catheter for doing that for definitive treatment for pneumothorax. But you can, use a needle and with a 3-way stopcock, and you can drain that air out of there. Is it thought process? Anybody ever watch that? It's like an old movie now. That Three Kings with who was it? Mark Wahlberg. He was Mark back then. And he's walking around with like a 3-way stopcock on from his pneumothorax to let the air out when he got shortness of breath, and a little 3-way stopcock. So similar treatment to that is what the catheter aspiration is. But what we do most of the time in an atraumatic, large enough to drain pneumothorax, what we call a pigtail catheter. It looks like a little pig's tail. They're relatively small. I want to say they're 18 gauge, 20 gauge. There's different sizes of them. That's usually what we use now for those smaller pneumothoraces that require a chest tube. There's some evidence to show even larger ones, you can use a smaller catheter. We don't need to get into all that. Nice thing is it's a smaller incision. You're not having to make, usually you're making like a 2 centimeter incision and you're placing a 36 French tube, which is pretty big. Because in trauma, we're trying to drain, there's usually blood in there and other fluids, so we're trying to ensure that we can drain that appropriately. But for these smaller ones, the pigtail works great. You don't have a giant scar there. So here's our chest tube. So these are best for the larger pneumothoraxes, recurrent, any coexistent hemothorax. So if there's blood in there, we want to use a larger tube. We typically use a larger tube to drain those out. And then like any tension physiology, we're going to use that larger size tube. And you can see the different sizes there. So smaller ones, the 10 to 22, and then you got your large bore, which is typically a 36 French. And that's what comes in your guys' medical equipment sets as well if you're in the Army and you're having to perform one of these. We also have chest tube kits, which that come pre-packaged with everything in them you need that don't come in your equipment sets, but we recommend ordering them, and we have some for you guys to use and to play with at our lab. Once we place the chest tube, we do put it under water seal drainage. Anybody know why? We use a water seal. It's called a Pleurovac. It's like a big little machine with some water in there.
So it's like a...
Yeah, one of them. Yep, sealing is one of them. And then the other reason is if we hook it directly to wall suction, we'd probably like suck their lung out of their chest. So it actually creates a lower pressure system. So usually under 20 millimeters of mercury has shown to improve rates. So you'll have those as well. And if you're placing a chest tube, especially in like an aid station or roll 1, you're going to want to have your Pleurovacs with it. However, we do have like one-way drains and valves and other little things we can use in a like combat setting. And then let me see if I can get this video to work. It's short, don't worry. I don't like long videos. I watch everything like 2 times speed too, but I won't do that to you guys. Almost there, don't worry. I'm not like handicapped with computer technology. And always gives like a bunch of pop-up errors.
Welcome to Medics for Medics. This video will show you how to insert a chest tube for a pneumothorax. This patient has multiple rib fractures. They cause a pneumothorax with a midline shift, forming a beginning tension pneumothorax. Sterility is very important, so make sure you know and follow the standard operating procedures of your hospital.
We're gonna do that in the trauma room. We should put on sterile gloves.
Prepare your table with sterile instruments. We'll be using a surgical clamp, scalpel, and surgical sutures. Use lidocaine 1 or 2% and determine the right chest tube size. The preferred patient position is half-seated with the arm lying aside and at shoulder level. Disinfect the thorax broadly to prevent desterilization. Before draping the patient, define intercostal level 4 to 5 to place the chest tube. Preferably use a broad sterile drape with a central opening. Anesthetize the skin, covering the rib that you're using as a reference. Now anesthetize the deeper layers above the rib. Then infiltrate the intercostal muscles until you enter the thoracic cavity with a needle. Make your skin incision 2 to 4 centimeters long and parallel to the rib. Now use your surgical clamp to dissect the subcutaneous tissue. Perforate the pleural membrane using your surgical clamp. You can use your index fingers to prevent deep perforation that might damage the liver or other tissues.
I mean, you shouldn't be in the abdominal cavity.
Now widen the intercostal wound using your index finger. Introduce the tube in the thoracic cave. You can see and hear air escaping through the tube. The tube is oriented in posterior and upward direction. Place enough sutures to prevent air suction. Use suturing wire to keep the tube into position. Keep sterility in mind when connecting the tubes, and beware to fill the drainage canister device beforehand.
There's your blur bag.
Start the vacuum and see how the air bubbles in your canister device. Adapt the vacuum if necessary. And finally, take a new X-ray to check for the tube position and the lung expansion.
Yes, you always want to get a chest X-ray after you place a chest tube. It'll be on your surgery block 3 chest X-ray. All right, so there's a little overview of how the chest tube is placed. Normally in the emergency department or trauma room, they don't consider it a sterile environment, so we are always wearing a gown, not a sterile gown, and our cap and mask, and then we'll use sterile gloves as well. Normally, most procedures aren't sterile there, so we just keep a pair in our back pocket and we pull them out if we have to do a chest tube. A couple pointers on there. If you have time to dumb it up, that's ideal. A lot of times in the traumatic setting or tension pneumothorax, we usually don't have. Time is not our friend, so a lot of times we'll sedate them a little bit if we have enough time, and then we'll perform the chest tube. So you want to go make your incision on the rib like it's a cutting board, so you're not just stabbing straight into the thoracic cavity. And why do we go above the rib versus below it?
Avoid the bone vasculature in there.
Yeah, you want to avoid that neurovascular bundle. So you got a bunch of nerves there, you have vasculature, so you'll get excess bleeding if you do it below the rib. So we recommend going above the rib. So there's no, like for treatment, especially for those spontaneous pneumos, there's no real clear difference between whether we're using a small pigtail catheter, a tube, versus just simple aspiration. The reason we a lot of times use a pigtail catheter nowadays so we can leave it in place, it's small, but a lot of times the lung won't completely resolve and we'll want to monitor them over the next 24 hours or 8 hours, and we'll repeat the chest x-rays, and if we don't have sufficient reinflation of that lung, then we still already have a tube in there, we don't have to perform another procedure. That's another reason we don't usually use the needle aspiration or simple aspiration very often anymore. And then, you guys know what pleurodesis is? So it's a procedure that basically sticks your lung to the chest wall. So a lot of times they'll have to perform a pleurodesis, and we use some sort of basically toxic or irritating substance, so we create an inflammatory reaction. So talc is a very common treatment we use for it. So there's talc powder. If you've ever seen those old prison movies where they throw all the white stuff on the guy when they show up, that's like talc powder. Doxycycline is another one that they use. It'll create an inflammatory reaction in there, and it helps stick your lung back to the chest wall after we remove the air. All right, so we have, there are treatment complications with this. Re-expansion lung injury is one we always talk about, but it's relatively rare. And if the collapsed lung reinflates suddenly, it can lead to downstream effects, which is another reason why we want to monitor these patients and get them into the hospital. And we take, every day we get a daily chest x-ray, we check how much drainage from the tube, and then we evaluate how much fluid in the last 24 hours, and then if it's less than 200, chest x-ray is normal. And a lot of times we'll pull that chest tube out. All right, so let's talk about other types of pneumothorax. So one of the subsets is iatrogenic, which means we caused it. So, and this, not common, but it's not uncommon. So some of the procedures you'll see, anything involving the thoracic cavity in a surgical suite, you run the risk of iatrogenically causing a pneumothorax. In The emergency department, we run the risk more often with like when we're doing a central line or a subclavian vein catheterization. It has a higher chance of causing a pneumothorax because if you think about where the subclavian is, it runs under your clavicle here, so you're right there on the lung. So if you're not using ultrasound guidance, you can run a risk of causing pneumothorax in that lung. So once again, like after we do a chest tube, we always want to get a chest x-ray, and after we get any sort of central venous line, we want to get a chest x-ray as well to evaluate whether we cause pneumothorax. Like I just said, get that chest x-ray. You can do a bedside ultrasound immediately after the procedure as well, but the standard is getting a chest x-ray. All right, and it's the same treatment as like a spontaneous pneumothorax. Depending on how large it is, we'll monitor it with oxygen. If it needs, if it's large enough, we'll put a chest tube in. If not, we'll just give them oxygen. If there's any tension physiology, then we need to treat that immediately. All right, and then what are some considerations after they get a pneumothorax? So sometimes we worry, like if we're evacuating patients or treating them in like a combat setting, we can worry about whether we can collapse that lung by sending them up to altitude. But if you have a chest tube in there and there's an open connection, then there's usually no risk to that patient. But after they have a pneumothorax, most guidelines suggest no air travel for 1 to 2 weeks after resolution. And then I think my buddy's kid, they actually went to Mexico like 7 days later, so he was like right at that mark, but he didn't have any issues. Other issues are diving. So, because of the pressure that's with diving, there are, documented cases of spontaneous pneumos from diving. However, the risk is relatively low. It is like a disqualifier to be a diver or a pilot if you've had a spontaneous pneumothorax. So I told my buddy's kid, I was like, sorry, you're not going to be a pilot or a diver, man. Unfortunate. All right, so we're usually not discharging these patients home. However, small pneumothorax, the patient's stable, you see the improvement with oxygen, and you've got repeat chest x-rays that are normal. Textbook, you can send them home. What's tricky in the emergency department is we have to decide whether we think this patient is safe to send home, and we usually err on the side of caution, so we will consult surgery and try to usually admit these patients. And then randomly, if the surgeon's evaluating, they won't take them, that might be the only time you send them home. But most of them are going to be admitted for at least 24 hours so we can confirm resolution of that pneumothorax. And then anybody that was like the tension physiology, they're unstable. After we resuscitate and place a chest tube, then we send those patients to the ICU. All right. So, 19-year-old male presents to the ED complaining of sudden pain in his chest, difficulty breathing that started while at work, denies history of trauma, recent illness, past medical history, vital signs, stable, unstable? Unstable, right? So the right lung fields are cleared auscultation, left lung fields are diminished, rest of the physical exams are unremarkable, bedside ultrasound shows a positive pneumothorax on the left side. So we're saying this patient has tension physiology was going to be our first treatment option. Needle decompression followed by tube thoracostomy. Now, what if this patient's vitals were stable? What would we likely do if it's a large pneumothorax? Tube thoracostomy, right? So the patient's stable. We don't need to put that needle decompression in there. We can safely do a chest tube sterile like they did it there under a more controlled environment versus in the emergency department. If anybody's ever worked at a trauma center, it looks like complete chaos all the time. So it's not the environment I would want a chest tube in, but if it saves my life, hey, great. All right, there's some great pictures there. What questions do you guys have? All right, take a 10-minute break, be back at 10 o'clock. I'm gonna do the aortic dissection lecture, not The next lecture is ACS, but that's a long one, so I'm going to wait and use that for a full 2 hours. So we're going to do aortic dissection. Emergency department is aortic dissection. Why? Because a lot of patients die from it, if they even make it to the hospital. So we'll talk about aortic dissections and some other related aortic syndrome, and then we'll cover a little bit over hypertensive emergency and urgency, which technically isn't a thing, but we'll get into it. There's your tin nollie. You need to stop the bullet, carry your tin nollie around. All right, so we'll define aortic dissection, and we'll epidemiology, pathophys, pretty much the same stuff we talk about and everything, and then we'll finish it up with some hypertensive, urgency, emergency, and the nuances there. All right, here's your warm-up case. 75-year-old male presents to your ED with complaints of sudden onset, severe, ripping chest pain with radiation to his upper back. Very concerning, right there. Blood pressure 197 over 99, heart rate 92, temp 98.6, respiratory 24. So this is a concerning patient, and a lot of times it is associated with hypertension. You guys think it's a high blood pressure?
Yeah.
Pretty common in the emergency department. So,
A little bit.
I mean, we see stuff over 200, over 100 all the time. Oh, my mic going. Oh man, is it working? All right. Hopefully the battery ain't dying. So yeah, and that's why we'll talk about hypertensive emergency and urgency, what we do for them, what's a concerning blood pressure. But yeah, blood pressure's a little high. So this one's going to be, what's important to think about for these aortic dissections is how the mortality rate in them and how deadly it is. So anytime we suspect a patient with any like indication for dissection, we manage them extremely aggressively just because of one, the location is the largest vessel in your body, and they can have severe complications, especially if it like ruptures, depending on how large the dissection is. So we get our safety net on board quickly, and then we'll talk about what labs and other diagnostics we're going to use for this throughout the lecture, and what is important to immediately control. All right, so there's our immediate actions, IV O2 monitor. Any suspicion of this, we aggressively manage before we do any imaging normally, so we want to start with our some sort of beta blockade, and then we want to use an antihypertensive agent as long as it's not contraindicated. And then these ones go to urgent, they get urgent surgery for these, most of them. We'll talk about the ones that don't. All right, so aortic syndrome encompasses several different, deadly emergencies. The most common one that we talk about is aortic dissection. But then we can also have they can have an atherosclerotic ulcer, an intramural hematoma, and then other aneurysms as well. Did you guys talk about AAAs yet in surgery? Yeah, so AAA also encompasses this. The issue is they're difficult to diagnose. They require CT angiogram, which takes a long time to get. We have to give contrast. So that's why we are always worried about this if we suspect it, and why we manage it aggressively from the initial onset. Like it says, frequently fatal. So that's a 10-year survival rate if they made it to the hospital and had treatment. It's a lot higher for just from the outset of when you initially have the dissection. Any traumatic dissections are usually fatal. All right. So usually in the setting of chronic hypertension, you get some sort of degeneration of that intimal and medial wall of your aorta. Then it creates a space in there in between like your adventitia. And then you get blood that kind of tracks through there, and it's not able to flow through the body, and it can be extremely deadly, especially as you get, the larger the dissection. You can also see it with like those connective tissue disorders like Marfan syndrome, Ehlers-Danlos. It does have a familial predisposition, so that's one. If I'm suspecting like a AAA or a thoracic aortic dissection, that's one of those few past medical history questions or family history questions I ask. I usually care if you have like sudden unexplained death, Or if I suspect this, I want to know if you have a family history of any abdominal aortic aneurysms. And hopefully they look at me like they have no idea what I'm talking about. I'm like, good. Probably don't have a family history of it. But it does run in families. And then you can also have associations with like cocaine use. Not as common anymore, but still out there. Amphetamine use, anything that like kind of increases that hyperadrenergic state can accelerate that atherosclerosis and increase your risk for dissection. Any prior cardiac surgeries, pregnancy has like a 4-fold increase. Risk of aortic dissection, still uncommon, but it is something to consider in a pregnant patient. So dissection and aneurysm are different pathologies. So aneurysm is kind of like a ballooning of that structure, whereas dissection penetrates through that intimal wall into the media, and there's blood in there. So one of them is just like kind of like just in a large vessel. And I think you guys talked about like saccular and all these other different types that we in surgery class. But we usually differentiate it whether it's the thoracic aorta versus the abdominal aorta. And then we have different classifications. I know everybody likes to memorize classifications. No, I'm not going to ask you what classification they are. The emergency department, we're super concerned. Any classification of this, so we treat them the same way and aggressively, and we call the cardiothoracic surgeon if we diagnose. But there's a little bit of our, like a pictorial representation or pathophys. We've got that intimal layer. It dissects into the media. And then the adventitial layer, if it holds, then you'll have that dissection, or what we call a dissection. And then men more common than women, and then, blacks greater and whites greater in Asian. And most commonly it's at that start of the ascending aorta and just beyond the left subclavian. So because of all the different structures and vasculature in that area, nervous system, it can present similarly to like even a stroke type patient. So we always want to consider this when we're treating a stroke as well. All right, so we got that bimodal distribution, so young, and we see in young folks with connective tissue disorders, they normally aren't diagnosed yet, so this might be their initial presentation, and then over 50, and especially with hypertension, ischemic heart disease, it's going to be more common. Like abdominal aortic aneurysm, you see, smokers is another common risk factor for it. Like an interesting fact, they occur more commonly in January and in the early morning between 7 a.m. to 12 p.m. It's random, but that's the same with like acute coronary syndrome. More often, like early mornings is when somebody has a heart attack. I feel like we see them all day, don't we? All right, so here's our different classifications. We got Stanford and DeBakey. So Stanford, usually easier because there's two things, A and B. One, depending on whether it's involving your ascending aorta versus your descending aorta. Now we have our DeBakey classifications. And then here's some pictures. So here's our Stanford. We got type A and type B. So as you can see, then they break it down into like type 1A versus type 2B. The biggest concern is with that ascending aorta, so they classify it as type A for the Stanford, and then type B for the descending. All right, so what do they present like? The classic patient, like on that first intro slide, you get that, abrupt, severe chest pain, radiates to the back, feels like a ripping sensation. It can be between the scapulas. What else presents like that? Is that? Yeah, ACS could, yep. What do we classically, with the radiation to the back, what else? We had learned it last week. Yeah, like pancreatitis can present similarly as well. Usually they say it's the worst pain they've ever felt. And half will say it's like a tearing or ripping pain. Sometimes patients aren't able to describe things to us appropriately. Our concern, if you see any of this chest pain radiating to the back, and you have any like neurologic symptoms, that's very concerning for dissection, just because it could be dissecting in that important vasculature we have, like our carotid arteries and other places. So 60% had anterior chest pain. With the descending aorta, it makes sense to have abdominal pain, especially in our AAAs. And then, like I said, anywhere near the carotid arteries, they can have those classic stroke symptoms. So it's always important that we consider this and in our history, whether they had any chest pain prior to this, any radiation to their back. I love how it says, like may lead to paraplegia. There's another slide you'll see. It's funny. It's like evaluate them for paraplegia or quadriplegia. I'm like, I think that if they're conscious, like I think that would be a big complaint. They're like, I can't walk, I can't use my legs, they don't move, or my arms. All right. So history, it can present flank pain, back pain, abdominal pain, and I think that was on the last EMED test about what we commonly misdiagnose. Nephrolithiasis is the most common misdiagnosis for AAA. One of the issues is, or complications can be a cardiac tamponade if it's close to the aortic root. And then we want to get some history on whether they're, any illicit drug use. Are they pregnant? Have they had any recent procedures? That's important. Any trauma, hypertension. And like I said, family history is important, so any AAAs, aortic dissections that they know of. All right, so here's just some of our differentials of consequence. So, like I said, it can present like a lot of different things. So they can have acute coronary syndrome, they can have any pericardial disease, myocarditis, pericarditis, cardiomyopathy, stroke. Some, if you guys remember, like that vertebral artery, they can also present similarly with that musculoskeletal type complaints. And then we get any, abdominal pathology as well, pulmonary, pretty wide differential for these. And then here's our clinical features. A lot of times our physical exam is relatively abnormal. Some things we might notice if our fingers work appropriately. You might notice like a pulse difference in the extremities. So it's important that we evaluate those in all our patients. So usually, check pulses in all 4 extremities. They're usually hypertensive. If they're hypotensive, that's usually like they're have either a rupture or a significantly large dissection and they're not able to compensate, and that's a worse prognosis. You sometimes can hear aortic insufficiency murmur with these, but not commonly. Like the big things are the pulse deficits, doing a good neurologic exam. They can present with like that Horner syndrome type picture as well, just because the vasculature in that area. So, our physical exam and chest x-rays and labs, none of them are really diagnostic for an aortic dissection, which is what makes this, extremely complicated. We have to keep it in the back of our head in any of these patients that they may have a dissection, especially with the appropriate risk factors and history and presentation. A lot of times it's, the mortality is so high, we might get tricked because they walked in and they presented initially perfectly fine and they were stable. Chest x-ray can show that wide mediastinum on there, and we'll look at some chest x-rays here that have it, but they might have some non-specific symptoms. They can present with syncope. So we are going to get an EKG in all these patients, and a lot of times they're non-diagnostic because they can, you may get some new Q waves or ST elevation, but that's very rare. Sometimes ST depression, but what we see most commonly, and this is like with everything, is just those non-specific ST and T wave changes are what we see most of the time in these patients. And that's what can make it tricky. So if we see any like ischemia or depression, we might think it's acute coronary syndrome, but it ends up being aortic dissection, which is why we need to keep that in the back of our head, especially some of those risk factors on there in their history.
Sir, when you say ST and T-wave changes, is that while they're inpatient there on that one visit, or is it like comparing to previous?
So it's a great question. We wish we had a prior EKG. So if we have new changes, it's more suspicious that something's going on. But normally we don't, and we just see like basically, and we'll talk about in the next lecture. You'll have changes, like one lead will have some inverted T waves or ST inversion, and then you don't have any reciprocal changes on there. So that's what we mean by kind of non-specific. They don't fit a similar pattern. They don't meet the definition for like ischemia or infarction. And we really don't know what to do with it. We know something's probably wrong, especially if we have a prior one to look at. And then we can say, oh yeah, there's new changes on here. I think something's going on. We need to either talk to the cardiologist or the cardiothoracic surgeon or do further evaluation on them. But yeah, they're usually non-diagnostic. Some of the biomarkers, like D-dimer is not a great test for this, for ruling it out. Troponin can be elevated in it, so it doesn't help much. What's important is because of the mortality rate and the risk of bleeding, we do want to, if we suspect this, we want to get a type and screen on them immediately in case and cross-match in case we need to give some blood products to that patient to resuscitate them. All right, so, if we can see it on the chest x-ray, great, that helps us initially. And a lot of times if the patient's stable, to get a chest x-ray first, and we'll see that widened mediastinum, the normal aortic contour. Depending on how significant it is, they might have a pleural effusion, depending on where it's dissecting at. And then we'll talk about that calcium sign and some of those other findings we might see on there. All right, so here's what do we see on this one? Normal chest x-ray? Normal chest x-ray. It's actually I love putting normal stuff on exams. I didn't do this one, but just because everybody gets so confused. They're like, is this a normal deviation? I don't want to say it's normal. Sometimes normals are normal. But you should see your aortic notch up there, or knob, and then you should see an outline of your ascending and descending aorta on there. And you're just evaluating on how large it is. There are measurements you can take, like over 8 centimeters. But this one is pretty significant, so, not normal. There's a wide mediastinum on there. You got that loss of the aortic knob. So this is a concerning patient. And we usually measure it at like T4 for the width, so anything over 8 centimeters we call positive. All right. So this is the calcium sign. So you get that calcified outline of the aorta. And then you see soft tissue beyond the border of it. So this is dissection, creating an extra lumen, so we call it a calcium sign. This one, kind of hard to see the costophrenic angles, maybe there's, maybe some pleural effusion on there, but how do we diagnose it? So we get a CT angiogram of the chest. And really, it's like CT of the aorta. So it's really confusing in medicine because there's like 8 million different names for everything. CT with contrast, non-contrast, angiogram. So angio means we're timing it to the vasculature of the aorta. So for this one, some places may call it CT angio, aorta, CT aortogram. But we want to basically time that contrast so that we're able to visualize the entire aorta throughout the process. So that's how we do the different CTs, especially with angio. It's just the timing of the contrast when we're taking those images on them. But this does have a extremely high sensitivity and specificity to rule this out. So it is going to be our initial test of choice if we have time for it. And then here's a normal. So abnormal. So you got a false lumen. You have the true lumen there with the arrow on the top. So on the left side is the false lumen where it dissects. You can see that tissue there. And it lights up a little bit darker on there. Your contrast isn't as prominent. Then you see the other arrows, your descending aorta. So you see it there as well. So that's abnormal. Kind of see that leakage of contrast outside of it, which is another abnormal finding. This is what you'll see on your CTs when you get them. And there's, kind of a better representation there. Do you guys see where it's dissecting? You have that darker colored line throughout the aorta. So there's a, smaller dissection, but still concerning. All right, so what are some other tests we can do? So we can actually do a transesophageal echocardiogram, which is not expedient or not something we do normally in the emergency department. This is more like on your inpatient side of the house in a under moderate sedation in a controlled environment. So they basically have to stick an ultrasound probe down the esophagus. So as you can imagine, that's not pleasant, so the patient needs to be sedated for that. And it's not as reliable as our CT angiogram in these patients. And then MRA is great, but magnetic resonance imaging is not something that usually can acutely be ordered or completed in the emergency department. So we don't use it very often. However, some facilities, especially like stroke centers of excellence, may have MRI emergently available. But there's how it looks on your ultrasound. So you get your true lumen and your false lumen, and you see that intimal flap kind of in the middle there. And there it is again. All right, so what do we do for these patients? So our initial concern is going to be controlling the patient's rate or their heart rate. So we want to rapidly reduce that to below 60 beats a minute. So we want to control the rate, and then we vasodilate to lower that blood pressure so that we don't have any shear force on that intimal flap that you guys that you saw dissecting on those last images. So, the ideal treatment of choice is going to be our beta blockers. So short-acting ones or esmolol is going to be the most common. So it's really fast on, really fast off. It has a really short half-life on that medication. So we can easily correct it if we overcorrected the blood pressure when we're treating them. We can also use labetalol as well as a second line if for some reason we can't use esmolol. And we usually want to drop that blood pressure below 120 is the recommended guideline. So some vasodilators we have, nitroprusside is one that we can use on a patient. Sometimes it works really well. Sometimes we may, we can run into issues with overcorrection. We can run into issues with, dropping their blood pressure too low. So another option we have is nicardipine we can use. And nicardipine is a good one, especially if they have an allergy to beta blockers. So we can use nicardipine instead of that. We use nicardipine instead of the nitroprusside, or we can use nicardipine instead of the beta blocker or esmolol. And then other options are like nitroglycerin. Clomidopine still on there. I've never used clomidopine, but it's been on the slide since I went through phase 2 or phase 1. All right, so labetalol is another option. It is it has a higher beta blockades versus blood pressure control. So it also does control your blood pressure. So it can be a great medication to use because it'll control both of them. However, usually labetalol alone won't decrease the blood pressure enough as monotherapy, but this is another option we can use. So, and we usually start these immediately. Like I think the last one I had, they had like a pulse deficit, and we start the beta blocker and the vasodilator immediately, and then we got the CT angiogram. It was actually negative, so then we stopped all the treatment on it. But that's how aggressively we manage those. We suspected, we're like, oh crap, because this is can be significantly life-threatening. All right. And then once we diagnose, we immediately refer them to the vascular surgeon or cardiothoracic surgeon, regardless of where it is, and we let them make the decision. And then they look at whether it's ascending versus descending aorta. So right now, like the ascending aorta is the most concerning, and they do an emergent endovascular repair on these patients. So all those type 1 dissections. And then type B, we try to medically manage with that rate control, blood pressure control. And then they decide with the surgeon whether there's something that they want to repair versus treat them medically or medically manage them. So that's going to be based on, age, patient risk factors, lifestyle decisions. And then there are other ones like, they've tried stenting, don't work well. Endovascular repair is the best therapy for it. We don't know the long-term benefits. Like even with repair, like I said in the first slide, 57% mortality rate still at 10 years. So, not the best. We don't have the best interventions for this right now. So these patients usually have a poor prognosis in the end. But the endovascular repair is easy, it's minimal. They can do that without having to open the chest. So there's a couple different ways we can do it. But that's more like surgical lane, not an emergency department. Our goal is we want to stabilize it. We don't want to expand it anymore. We want to reduce that shear force on that intimal flap, and then we want to refer them to surgery. All these patients are going to be admitted to the ICU or surgical ICU. Most of them will be taken emergently to the operating room if it's an ascending aortic dissection. And then there are other complications or mortality we see with this. So if it's a penetrating ulcer, those ones get a little bit more complicated. It's not something in our lane that we really need to differentiate. We need to identify that they had a dissection, regardless of the cause, and then refer them for emergent treatment of it. None of these should be discharged home. All right, and like I said earlier, it's rare in pregnancy, but it does increase their risk by 4-fold versus non-pregnant females. So if we suspect this, we want to consult with OB and the cardiovascular surgery immediately, and they can decide what the best treatment options for how far along in pregnancy. I'm usually in the 3rd trimester postpartum, so you still have a reasonable chance of delivery, but we want to coordinate with our OB colleagues on this as well if they need to deliver. And then here's some, mortality can have, you can have multiple complications with a dissection that increases our mortality. So like acute cardiac tamponade is one that we worry about. Depending on, especially if we have a bicuspid aortic valve, we have an increased risk for that aortic insufficiency. And you can have free rupture. You can start getting ischemic changes, especially anything distal to where that dissection is, and depending on how large it is, if you're not able to adequately oxygenate all those tissues there. All right, hypertensive emergency and urgency. So these are always a fun one. It can be confusing because the blood pressure is really high. So the question is in the emergency department, do we want to lower that blood pressure? It can be tricky because how long have they been living with that blood pressure? Probably a long time. So when we acutely lower blood pressure, we then worry about like ischemic changes into the brain, stroke type picture. So it's tricky for us in the emergency department. And we actually have guidelines and they've done studies on it. So we actually don't want to give them any acute lowering blood pressure medication unless it's an emergency. And the difference between the emergency, we usually say, typically systolic 180 to 220, but we only treat this if they have any signs of end organ damage. So this is important, like we think about our brain, eyes, heart, kidneys, lungs. So we need to, if their blood pressure is high and they're symptomatic, so they have this hypertension, they've got a headache with it, or chest pain, then we need to further evaluate them with like an EKG, troponin. We need to get labs to look for any sort of kidney dysfunction, get a chest x-ray, CT of the brain. And then if all those are normal and we don't see any end organ damage, we usually don't treat these patients after the evaluation. Now, if we see any of those affected, then we look at lowering their blood pressure. But we are very hesitant on how quickly we want to lower it. So the recommendations are 20-30% in the next hour. And then they get admitted, we manage them for days until we normalize that blood pressure. If we do it too quickly, like I said, they can start to get those stroke-like symptoms. And anybody that we have acute concerns for dissection, we start the esmolol, but we can also use nicardipine and other medications to treat them as well. Now, urgency. So this is that similar patient. They've got elevated blood pressure, so they're systolic, usually over 180, some say over 200. The question is, what do we do in the ER? So we know that if we treat them, we run the risk of some sort of ischemia to some of the other structures or their brain or anything else. So when these patients present to the ER, the guidelines right now are we actually, if they're completely asymptomatic, we don't suspect any signs of end organ damage, we don't actually do anything for them. So an asymptomatic patient, a lot of times we'll take a good history, physical exam. We'll want to know what any prior blood pressures they've had taken, and then we arrange them for follow-up, and we don't attempt to control the blood pressure immediately. Now, if they have any symptoms or symptomatic, that's when we do all of our ancillary testing, labs, and everything else. This is something that's commonly you'll be pimped on in phase 2 with somebody with 190, and the preceptor will be like, well, what do you want to do for that? And the question is, well, is symptomatic? No. Well, we actually don't do anything for it then. And we have, the American College of Emergency Physicians has guidelines, and that's the appropriate treatment standard of care. We don't call it hypertensive urgency anymore. It fell out of term. However, it's still in your ICD-10 codes, and that's what we call it. But nomenclature, we don't say it anymore. But for these patients, we don't do a lot for them. And most of them show up because they had an elevated blood pressure, an at-home blood pressure check, it's 180. They don't, they hadn't checked in a while, they don't know what it normally is. So this is a very common patient you're gonna see in the emergency department. All right. So you got a 40-year-old male, past medical history, bicuspid aortic valve, presents to ED, sudden onset, severe tearing chest pain radiating to his back. Left upper extremity pulse markedly reduced compared to the right. Well, we talk about important history, so any, prior history of any, family history of any aortic dissections. We want to know whether this patient has any history of hypertension. He already has a bicuspid aortic valve, which is concerning. Got that pulse, extremity pulse difference compared to the other side. What do we want to do immediately for this patient? Yeah, we want to control the rate, and then we want to look at controlling that hypertension, so vasodilate them. The differential is still pretty broad in this patient. He does have a risk factor of that bicuspid aortic valve, so it does increase his risk for any sort of other pathology with a dissection. But what test do we get for this? CT angio. All right. And yeah, this patient, depending on what we find on there, we want to admit them to the hospital or rule out whatever is causing their chest pain. So evaluate for ACS, anything else. All right, I know that was quick. What questions y'all got? You guys are just hungry, ready for lunch? All right, I'll stick around if you guys have any questions, but have a good day.